Now we're going to look at the calcium, phosphorus, and parathyroid hormone disturbances in chronic kidney disease. And the last slide would be a summary slide where we're going to try and label the following disorders in calcium and parathyroid hormone levels. We're going to find a name for the situation where we're going to find low calcium and low parathyroid hormone. We're going to have to give a name for a situation with high calcium and high parathyroid hormone, high calcium and low parathyroid hormone, and low to normal calcium with high parathyroid hormone. Before we look at what happens in chronic kidney disease, just a word about how phosphorus is regulated by the body. We talked a lot about calcium, but let's spend some time talking about phosphorus. So, if someone has a high phosphorus intake, say from soda, milk, the high phosphorus level is detected by osteocytes, that is the bone cells, and the osteocytes release something called FGF23, the fibroblast growth factor 23. The FGF23 then brings about excretion of phosphate into the urine. So this is how high phosphorus levels in the blood are able to be regulated by FGF23 by its action on the kidneys. The FGF23 also has another action, that is, it inhibits 1-alpha hydroxylase, which we discussed is the last step in the activation of vitamin D. And so if you have less 1,25 dihydroxyvitamin D3, there's less calcium and phosphorus reabsorption in the gut, and that again brings phosphorus levels back to normal. So when there's high phosphorus in the blood, the gut and the kidneys try very hard to bring the phosphorus levels back to normal. The symptoms of hypo and hyperphosphatemia in the ICU setting especially, you will see hypophosphatemia, and it does cause muscle weakness, trouble getting off the ventilator, so it's an important element to correct, especially in the ICU setting. Hyperphosphatemia, on the other hand, promotes vascular calcification and valvular calcification. You can see how the valve has kind of become like a bone. And symptomatically, some patients may complain of itching, but that's a very non-specific symptom. Let's look at what happens in chronic kidney disease. So there you have kidney disease from diabetes, high blood pressure, and there's a shrunken kidney there. When there is kidney disease, there are fewer nephrons, and the kidneys are not able to excrete enough phosphorus, and as a result, the phosphorus level in the blood starts to rise in chronic kidney disease. Remember that the high phosphorus levels in the blood are sensed by the osteocytes, the bone cells, that brings about FGF23 release, again from the bone. FGF23 then inhibits 1-alpha hydroxylase and calcitriol production. We reviewed that in the last slide. And so there is a decrease in the 125 vitamin D level, that is the active vitamin D level in chronic kidney disease. Also, if there are fewer nephrons to make 1-alpha hydroxylase, there's going to be less generation of 125 dihydroxyvitamin D. So there are these two pathways that cause a low calcitriol level in chronic kidney disease. What happens next? Now, the 125 dihydroxyvitamin D, as we have reviewed, it brings about calcium reabsorption from the gut. So if there's less calcitriol, there's going to be less calcium being reabsorbed. Also, some of the phosphorus, the high phosphorus in the blood, is going to bind the calcium levels, that ultimately leads to a low serum calcium level. And who is going to respond to this low serum calcium level in the blood, it's going to be the parathyroid hormone levels that are going to rise. The parathyroid glands are going to detect the low serum calcium levels and will bring about release of parathyroid hormone. This is called secondary hyperparathyroidism. It is called secondary because the release of parathyroid hormone is secondary to a low serum calcium level that was generated by these two pathways, the high phosphorus in the blood and the low calcitriol levels. This is not like primary hyperparathyroidism, where there is an adenoma that is independently secreting parathyroid hormone. The high parathyroid hormone levels will then bring about phosphorus excretion by the kidney. And that's how it's trying to keep the phosphorus levels under control. It tries to do it, but it's not perfect because there are fewer nephrons, but it does try to get the phosphorus levels down. And the high parathyroid hormone also breaks down bone, stimulates bone resorption, and tries very hard to normalize the serum calcium level, which, as we have learned, is very important to maintain the various functions, electrical, hematological, endocrinological functions in the body. Now, while the parathyroid hormone is trying to bring the calcium and phosphorus levels back to normal, the high PTH levels continuously cause bone weakening. It causes a kind of bone disorder known as renal osteodystrophy or osteitis fibrosa cystica. So you'll see these like cystic changes in the bone, which is a result of constant breakdown of the bone by the high parathyroid hormone levels. It looks a bit brown because of bleeding, the hemorrhage into the bone. And that's what causes bone pain and fractures. So to summarize what we see in chronic kidney disease, in secondary hyperparathyroidism, you're going to see a low to normal serum calcium. But keep in mind, you're never going to see a high serum calcium level in secondary hyperparathyroidism. But commonly, in the setting of chronic kidney disease, that is folks who have low kidney function or on dialysis, you're going to see secondary hyperparathyroidism where the calcium level is low to normal. You're going to see a high serum PTH level, a high phosphorus level, and a decreased 125 dihydroxyvitamin D. How do you treat this condition? So if you want to try and bring the parathyroid hormones, if you want to try to bring the parathyroid hormone levels back to normal, you're going to have to find ways of decreasing serum phosphorus level through the use of phosphorus binders, or you would need to find some way of increasing calcitriol by supplementing the patient with calcitriol. And that way we try to bring the parathyroid hormone levels back to normal to prevent bone breakdown.